Hello and welcome to another edition of the Osteopathic Lyceum podcast. The thing that I'm going to aim to speak about today is mechanisms. And more or less whether or not they are exceptionally impactful for how you're going to interact with somebody who presents for treatment. There's times when I stumble over how to say that because there's some places where the term patient is appropriate. There's some terms where the term client is more appropriate. There are some professions, hands-on, that prefer one term over the other, and it varies jurisdiction to jurisdiction. So because there's the high likelihood that across time, people in varying places will consume the things I'm attempting to share, I just want to make sure that it becomes apparent that I'm aware that there isn't one way to say this. But anyways, somebody shows up, you're an osteopathic manual practitioner or a hands-on practitioner of some other form, and they are asking you to help them. Does how, on an underlying abstract, non-tangible level, maybe not non-tangible, but on an abstract level, let me roll back just because that's going to get extra choppy, and it already has, so just pointing it out. Somebody presents for help, asks you for help as a hands-on practitioner. Does the underlying abstract mechanism make a gigantic difference as to how effective something's going to be? There's an argument that it does, and there's an argument that because people are variable, you don't get to choose one mechanism. You don't get to target one mechanism. You're targeting proxies for many mechanisms. So maybe a better way to say that is if you apply external pressure to a human body, and many other species in all likelihood would fall into this category as well, there's going to be some form of neurological sensation produced by that external touch or that external pressure. There is going to be alteration to local pressure environments. So you could start to talk about movement of some form of fluid. If you're talking about movement of some form of fluid, you can start to speak about movement of some form of substrate. So something in that fluid, hormone, chemical of some form. You can now talk also about the not just fluid, but vascular function. So there is local autoregulation of blood flow. So anywhere you essentially apply pressure external to something, inside of a human body, and again, many other species as well, there is some alteration of blood flow for a very short period of time in the area where the pressure is being applied. So these things, we're talking about three general concepts, maybe a little bit more, but are three named concepts or three concepts that I brought forward. All of those are at play every time that touch is, or that pressure is applied, that touch is applied. The question becomes whether or not it matters which one it is that is going to have the benefit to the person. The other deal at all times is there is top-down control of many processes, aka cognitive control. So you take something such as the diaphragm as a muscle. There is both, there is the ability to have conscious control of the diaphragm, so you can think about taking a deep breath. Now, there are other muscles involved, so trying to get down to just the diaphragm and saying it's just the diaphragm. When you do a deep inhalation and a deep exhalation, other muscles get involved aside from the diaphragm, so the diaphragm's involved. But you can have, maybe the better way to put it is you can have conscious control of respiration as well as relatively unconscious control of respiration. The mechanisms for that, or the controls for that, are somewhat dispersed and somewhat localized. So if memory serves properly, you have the apneustic and pneumotaxic centers, I believe, in the cerebellum. So there is some cerebellar control, but then you also have the phrenic nerve. You're going to have some sensory fibers. In other areas, you're also going to have innervation to the accessory muscles of respiration, more dispersed, so it's a slightly more dispersed thing. We can talk about any of the sub-elements, but we can also simply acknowledge that it is a little bit more complex. So just because I touch in a particular spot doesn't mean I have done the thing I think I did. So the top-down control element, so we use the diaphragm or respiration, say deep respiration, as an example of something that is both consciously and unconsciously controlled. So when I'm working on somebody, when I'm working with somebody, I can just allow their breathing to do whatever it does. I can ask them to breathe in a particular way. When I apply external pressure or external touch to them, wherever it may be, they may consciously alter their breathing without being asked. So all of that stuff could be happening that is outside of my control as the practitioner. So I have to respond to how that patient's responding. And I don't know necessarily in any given moment whether it's more of, say, a chemical response, a fluid response, a neural response, cognitive response. I'm not always sure which one it is. But what I can tell is when I have a goal, right? So I know what I'm trying to do. I have assessed the person. I found what's not moving particularly well, especially in comparison to a paired structure or a local structure. So if I'm looking at soft tissue and I squish in one area and it does not squish the same as surrounding areas, then I have some insight as to that would be the area that I would be curious about altering tone. I don't necessarily know what mechanism will make it harder for the patient to accept movement in the desired direction or in the desired form. I can tell when it's not working the way I want because I have the goal. I want it to move quantitatively more and possibly qualitatively smoother. So then I can bring in another concept, which is the barrier concept, which is described as don't make them say ouch, which is really avoid engaging protective responses. So if you need to generate cervical flexion, so dropping the chin towards the chest, but when you start to go forward, you feel some form of resistance, you feel some form of protective response. Well, if I turn the head to the left and then flex, I don't feel that protective response. I don't know necessarily if the reason that there's a protective response going straight in plane is because there's neurological sensation, because there's chemical sensation, because there's cognitive fear. I don't know why, but what I do know is that if I come slightly off axis, I can get more of it, and then I can start to test coming back into axis or a more true planar movement with respect to flexion after I start the movement. So when I'm clinically working with that person, they're going to respond in their way. I want to be cautious with saying a unique way because there's an abstract way you can say that all responses fall within particular ranges, so it's not necessarily that unique. Or you can say that it is unique because it's that person in that moment and interacting with that practitioner. So you can argue it in either direction. The point being that the person will respond in their way, and you know what your goal is, or you know what the goal that is clinically relevant to your approach is. So if I'm thinking about cervical flexion and I can't get it in straight plane, straight planar motion, then I come out of plane and work towards it while avoiding the observable protective responses or the observable resistance. I don't have to be able to explain how that happened to be able to repeatedly do it. So to be able to repeatedly get more of the desired motion to occur after identifying it as a restricted motion, I don't have to know how it works. I have to know how to respond to that person in the moment, because what I can say is, as a larger concept, if I respond to that person in the moment and how they're responding to the interaction between us, I'm paying more attention to them, I'm tailoring more to them, regardless of the neural, endocrine, fluid, vascular, cognitive, whatever mechanism is at play or mechanisms are at play in a united way that will make it harder to generate the goal motion. I don't have to be able to pick it apart to be able to do the most appropriate thing for that human being in that moment. The reason I want to talk about this and provide some framework or provide some rationale is because something that I've observed across time and I've touched on over time is that people get really, really interested in mechanisms. And I do not know to what end the mechanism is going to improve the therapeutic interface. The therapeutic interface is complex, not complicated. So the difference that I'll attempt to point out here, complicated is something where you know how each part works and you can predict how it will respond to a particular input. Complex, you cannot necessarily clearly, cleanly predict how it is going to respond to a particular input, right? So the human being that you are interfacing with is complex. You as a human being are complex. So you can't predict exactly how that's going to go. I have a strong appreciation for things in their appropriate place. So scientific reductionism helps you understand an individuated thing and helps you understand how it works in relation to the things it's surrounded by. So you want to figure out how something works. You take it out of its context to see what it does out of its context. And then you start testing it in relation to its context. So you do have to reduce sometimes. But other times, when you're not able to appropriately reduce, then you need to interface in a way where you're interacting with the complexity while respecting it. So you're trying to find something you can interact with in a way where you know what you would like to happen, and then you have to respond to what does happen. So let's just say you're looking at shoulder flexion, right? You want the arm to go up in plane more cleanly. So let's just say I do shoulder flexion. For those of you who can't see, my elbow is relatively off midline. It is relatively horizontally abducted. So I want to try to get that elbow back into plane, in relative plane. Well, if I bring it back into midline or towards midline, I adduct it, and there's resistance, I can't do it that way. But what if I generate some internal rotation and I start to bring the elbow, and now the elbow towards midline, and now the person isn't resisting. I am responding to the complexities of that human in that moment, and there is some neurological thing going on. There is some fluid-based thing going on. There is some endocrine thing going on. There is some cognitive thing going on. Which one of those is contributing more, I can't tell, and I don't need to tell. I need to acknowledge the complexity of the circumstance by paying attention to how the person responds in that moment to the clinical goal, which is that improved movement in relative plane. So lots of rambling to note that the over-reliance on mechanism as an explanatory approach is moving away from paying attention to the individual and how they're responding to the stimuli that is occurring while you interface, while I am passively moving them, while I'm actively asking them to move, while I passively move them into position and ask them to actively move something in relation to that position. There are many things going on. You simplify them to things that you can aim for and respond to, while recognizing that how it's working may not necessarily be as important. So how the clinical interface works may be less important than can you make it work in these variable circumstances, or can you get closer to the goal in these variable circumstances. The attentiveness to how the individual responds is more important than the mechanism, in my estimation. The mechanism has value, right? So research surrounding the mechanisms for how manual therapy works has value. One of the reasons it has value is because something that it is related to a phenomenon that I point out with a bit of a quip, right? Osteopathy does good work consistently, but its stories are crazy. So if that is a reasonable construct or construct that has any value, it points to good work by paying attention and responding to the individual in the moment, bad work on mechanistic claims, right? And the majority of osteopathic mechanistic claims are bad because they start from a place of certainty as opposed to a place of exploration. So people say, this is how it works because the anatomy is here. It may or may not be the case, and it may or may not be the case between individuals. So it may work in one, or it may be that rationale in one and not that rationale in another. So the mechanistic story has value because it can clean up some of the discussions between practitioners, between professions, as well as between practitioners and patients. So it can clean some of those stories up. But I would argue that you don't necessarily need to do that if you can generate an explanation based on how you and that patient have interacted. A simple way that that might look is when the person's like, well, how did that work? Or why did that work? I'm like, I'm not 100% sure why it worked, but what I do know is that this wasn't moving particularly well. When I went to that area and I applied pressure, you started to tense up. So I backed off on the pressure and then we got a better result. It can sound like that. I don't need to talk about this nerve, that nerve. I don't need to talk about this organ, this fascia, this fluid, because the more that I go below something that's observable or quote unquote deeper to something that's observable, the more assumptions I have to make. If I explain based on what observably happened, I'm making less assumptions. I'm more accurate to the circumstance. So something that I say over time is, if your explanation is focused on the movement, then you're making less assumptions and you're probably accurate to the circumstance, especially when you include how the person responds and why you changed based on their response. So I say had the patient in seated and I tried to generate shoulder flexion and there was resistance, and then I put them in supine and I generated the same movement and there was less resistance. Well, that's the one that I'm going to choose. My goal is to improve movement while avoiding protective responses. So my choices for changing my approach are based on the presence or absence of the protective response. That allows for meaningfully accurate explanation of what observably happened as opposed to what you're assuming is happening in a place that you can't observe. So the mechanism, I don't think, helps the therapeutic interface in many ways, aside from curiosity and the manner in which it is being searched for has cultural baggage, which makes it harder to find. I've made this argument in other words and other ways and other times, but I think it has value to come back to from time to time, just as a refresher for myself, partially in that it allows me to have different ways to speak about it. So different sounds in different orders to try to point to the same phenomenon. The phenomenon is not the words, it is not the sounds, but the sounds can point to it, especially if it's consistent. So different ways to speak about it, different angles to try to get people to connect to it, different examples to try to get people to connect to it, allow me to possibly be more broad-ranging in who I can try to deliver this message to and who can accept this message. So generally, I would argue that paying attention to the person in the moment, because you are complex and they are complex, aka you cannot cleanly predict how either one of you will respond to the stimulus. Like, the mechanism doesn't help that, but paying attention to that has the most appropriate opportunity for positive clinical outcomes or avoidance of negative clinical outcomes. And searching for the mechanism and thinking about the mechanism means you're paying less attention to the person in the moment. You're paying more attention to the idea. Paying more attention to the idea, it doesn't seem to allow you to connect and interface with that person in that moment as well as maybe you could otherwise. So this also is an underlying rationale for why I avoid, quote unquote techniques or quote unquote pre-named technical approaches, because they limit how I can interpret that patient in that moment. They limit how I can respond to them in that moment. Most people who use classical or previously named technical approaches will respond, they will alter to some degree, but it is less likely easy due to the cognitive pattern that somebody is probably going to be in. I can't say that definitively, obviously. That's why I'm hedging. That's why I'm being a little more cautious with my words. But the technical approach or the technique-based approach means that you have to remember a bunch of details. It means that you're less likely to pay attention to the person in that moment. But if you're paying attention, you know your goal, you see how they're responding or observe how they're responding, and you change your approach based on their response, still in the direction of the net goal, you're probably doing pretty good. Anyways, lots of ways and angles to try to say, hey, the mechanism probably doesn't matter to the clinical approach, especially with hands-on therapy, in the way that I think I'm observing people be concerned about it or care about it. So you can use a lot of cognitive energy talking about stuff that you can't observe and is not going to make you better. An argument that I've made in the past is that the mechanism is not likely going to change your clinical behavior. And if there was, say, a more meaningful mechanistic explanation that could change your behavior, by now we'd likely have stumbled across it and gotten closer to it. And it just doesn't seem to be the case. So thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.